Yeah, let me just read a little bit about what they've said about the MIST trials. So they said this trial will build on the results of the landmark MIST trial, which was the first in the world to show that stem cell transplantation could reverse disability in patients with multiple sclerosis. The trial also showed that AHSCT worked better than the disease-modifying drugs available at the time, which we were speaking about earlier, in reducing the risk of disability accumulation in patients with the highly active form of the disease. And obviously things have moved on since then. There are more of these high efficacy drugs available. Coming back to a point that you made earlier, I'm really interested, and I think I've spoken to you about this before, because you were very emphatic that no, this is not for secondary progressive MS, although there is this sort of overlap. And this is definitely not what they're concentrating on. It's relapsing remitting. They've made the point that in the MIST trials, and I know this was something that you focused on really heavily, was the fact that these patients, their EDSS score was reduced. So they were seeing quite a reversal in disability. But I know you've also spoken about secondary progressive patients who seem to sort of stay the same rather than having that reduction in the EDSS. Is that not some form of success? Because I know my husband, as you know, James, was diagnosed with secondary progressive, but I can appreciate he probably was just on that part where he was overlapping with relapsing remitting, and just he was on that point. So it has worked for him. He has seen a number of improvements, not in his mobility, because that's neurological damage has been done, but certainly in many other areas, and he hasn't progressed any further. So his EDSS is still 6.5, which is what it was when he had the HSCT, but we're 7 years on next year since he had the treatment, and he was going downhill very, very rapidly. It felt like there were new symptoms almost every week. So for him, he wouldn't guess it now. He was very, very lucky. He sort of managed to sneak in under the radar, I think, really, before it was as well known as it is. Is there any application in those terms, or do you feel that it's too much of a high risk treatment to just halt the progression in progressive patients?
Well, that's actually a complex question, because again, details are everything. So I will do active secondary progressive. What do I mean by active? I determine the clinical course of the patient determines whether it's secondary progressive. In other words, there's a slow gradual decline without a clinical relapse, or between the relapses, instead of getting better and then being stable. And that decline, you can see a patient every month, and all of a sudden a year later or 8 months later, they're worse, but you don't know when it happened. It's slow gradual. That's secondary progressive MS. So when it's active, what I mean by that is within the last 6 months or 12 months, hopefully 6 months, but I would take within the last 12 months, you still have enhancing lesions on MRI. That's active inflammatory disease. Then that's active secondary progressive. If within that last year you have no active inflammatory enhancing lesions in MRI, I would say it's non-active and I wouldn't do it. Now, there are people, you're right, with secondary progressive who get it and stabilize. There are others who continue to progress without new lesions on their MRI. Now, is their progression at a slower rate than if they didn't have this treatment? I don't know. My goal was always to try to reverse this disease and make patients treatment free. And although I never use the word cure, except now in my book, I put cure on the title, but the caveat in there that I never use it. And although we have patients 20 years with no evidence of disease and no treatment, got better, stayed better, there's no definition for cure for this disease. So, the study of secondary progressive should be done separately. I'm not saying you should totally abandon it, but it would need to be done separately. And probably if I were to do non-active secondary progressive, I would use a different regimen. And in fact, what I'm doing now, I've wanted to move on to my IPS work because we have great animal studies on that, of how we can use that for regenerating tissue. And I want to start applying that in humans. But because I see this field kind of often in confusion, I am continuing on, and we have an open trial now for transplant for MS, but it's two types of transplant. The way I've always done it, like on MIST, or how they're doing here on STAR MS with Cytoxin ATG, capped at 6 without CD34 selection. So 6 milligrams per kilogram total dose of ATG. That's important. You don't want to exceed that dose because you get into other complications. Versus that same dose of cyclophosphamide versus rituximab. And the advantage of the rituximab is you have no fever. The ATG gives fever. You're going to have to treat with steroids to break it. You got to give antibiotics and all this stuff. The rituximab won't do that. And that can make the transplant even less expensive and open the door for it to be done as an outpatient. Fever is bad for patients with MS. It's bad for damaged neurons. It's bad for demyelinated neurons. I believe it can lead to more accelerated neurodegenerative damage later, years later. That's actually in one of my JAMA publications before the MIST trial. We had a JAMA publication of 150 patients. I have that in there, but because they only allow so many figures, it's been put in the supplement by the journal. But for me, it was a very important figure.
Yes, I remember hearing you speak about it before, about the fever and the
yes, you don't want fever, especially if you're secondary progressive, and I think you want to use a different regimen, even lighter, that's not going to have that risk of fever related to the ATG. And so what I'm doing now is we have a trial where we compare Cytoxin, rituximab, and Cytoxin ATG. And the reason for that is I know they're going to be equally effective short term, but long term, will there be a difference of that's significant? Because the Rituxan ATG, the Rituxan cyclophosphamide will be cheaper with less fever. It'll open it up for this to be done as an outpatient. We'll make it even much cheaper. And that's the goal, is for me to, now that I've shown that we have a regimen works, to try to tweak it, perfect it, make it safer and even cheaper, and move this to an outpatient department. The goal with the STAR MS is a little different. They're going back with another randomized trial. Of course, I wish them well. I would avoid, like they're designed it here, secondary progressive MS. And I do think if there is some role for it, that's going to require further studies and an even safer regimen without risk of regimen-related fever. That would be Cytoxin rituximab, which is our comparative arm to Cytoxin ATG transplant in our current open trial that we're running at Scripps in La Jolla.